Hi, good morning, everyone. We're going to go ahead and get started if everyone wants to take a seat. So good morning and welcome to today's panel, How Medication Teaching Improves HCAHPS Scores. My name is Kristen Watson. I'm the Client Service Director for the West here at GetWell Network. During today's session, our presenters are from Atrium Health and then Kaiser Permanente, Panorama City, and they'll be sharing their experiences on utilization of the medication teaching pathway in GetWell Network and how it can positively impact HCAHPS scores. After hearing our presenters, I'll open up the floor for some questions, and you can also share your experiences of how you're using this pathway at your own facility. It's my pleasure to begin this morning's presentation by introducing our presenters. So first we have Misty Avery. She's a Senior Applications Specialist in the Health Division of Information and Analytics Services at Atrium Health. She has an MBA with a concentration in Healthcare Management from the University of St. Mary and a BA degree in Spanish and Sociology from the University of North Carolina at Charlotte. In her current role as a Senior Applications Specialist in IAS, Misty provides end-user educational support, utilization data, and interactive patient care consulting to 11 of Atrium Health's 12 acute inpatient hospitals that are utilizing GetWell Network today. Dennis Ramirez is currently working at Kaiser Permanente, Panorama City as the Department Administrator for the Telemetry Unit and has almost 9 years of leadership experience. He has earned his Master's in Healthcare Administration at the California State University Northridge and his bachelor's degree in nursing at San Juan de Dios Educational Foundation in the Philippines. He's a certified nurse manager and leader. Wendy Nahor Jose is a clinical nurse in the telemetry unit at Kaiser Panorama City. She is the incumbent chair of the diabetes committee called Sweet Talkers and member of the Care Experience Council. Her clinical background includes medical, surgical, telemetry, and step-down units. She has a degree in mass communication from the University of the Philippines and her nursing degree from Glendale College. She has worked on projects for quality and has presented her work at Southern California Kaiser Magnet Conference. And then finally, Roque Garvida is the Informatics Practice Specialist 2 and the clinical lead of GetWell Network at Kaiser Panorama City. He has been a registered nurse for over 27 years with background in psychiatry, long-term care, oncology, telemetry, adult intensive care, staff education, simulation, evidence-based practice and research, and nursing informatics. He obtained his BSN from the University of Santo Tomas and his master's from the University of Phoenix. He is board certified in nursing informatics, and he has been an active clinical leader of GetWell Network Innovation at Panorama City the last couple years. So thank you guys for joining us. Before we get started, I need to share a disclosure statement with you related to nursing education credits that are being offered for this session. The Maryland Nurses Association is an accredited approver of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. If you wish to receive credit for attending this activity, you must complete the session survey found on the conference mobile app. In the survey, it's important that you check the box indicating that you would like to receive credit and enter your full name and email address in the space provided. Your certificate will be sent to that address. In compliance with the continuing education activity credit conflict of interest disclosure requirements, we'd like to announce that the presenters of this session have no commercial association that would create a conflict of interest. I'm sure you guys have heard that several times over the past few days. So we'll go ahead and get started. Misty from Atrium Health will kick off our session today.
Thank you. So as she mentioned, I work with more of the end user education, helping our nurses and our frontline teammates use GetWell. My partner, Jessica Wilson, is in the front row. She is our technical component, so if you ask me any questions that have to do with integration, I'm probably going to look to Jessica, so just to let you know that. So Atrium Health, we're a pretty large organization. We're comprised of about 40 hospitals and 900 care locations across North Carolina, South Carolina, and Georgia. We currently have 12 hospitals that have GetWell Network live, 11 of which are the ones I'm going to mostly focus on today. We have 2,700 bed licenses for GetWell Network, so as you can imagine, it's a pretty big ship to run. We are fully integrated with Cerner, so all of our video education, all of our medicine teaching documents back to the EMR through the IPOC EATR section of the flow sheets. We started our partnership with GetWell back in 2012 with our first unit going live in December of that year. And we really want to use GetWell to drive patient satisfaction and engagement through interactive patient care. But my goal over the past 2 years has really been to empower the staff to realize this is a tool that benefits them as much as it does our patients, because if it doesn't work for staff, it's not going to work for the patients. So one of the opportunities that our system has always had was around medicine teaching, the communication about medicine's domain, and specifically the side effects question of that. So as you can see from this slide, it kind of shows a comparison of where we were in 2017 and then where we fell to in 2018. So we already had opportunity, and we actually decreased in our top box and percentile rank scores. And then in the purple, you can see our GetWell percent of patients using the See My Medicine space. And it wasn't ideal. Again, 2,700 beds, and we were at less than 10% of our patients really taking advantage of this tool. So we needed to know kind of where were the cracks in the foundation. Why are our staff not using this tool when clearly we have opportunity around medicine teaching? So we reached out to staff to kind of find out, what are the barriers? Why are you not using this tool to its full potential? So one of our biggest issues was we were using a 4-digit PIN code for the patient to see their medicines. And it was really good in theory for privacy from visitors not seeing their medicines, but it was such a barrier, they weren't taking advantage of it. So the cost kind of outweighed the benefits. There was also a negative perception of the tool that kind of culminated with nursing. So they had started the narrative that GetWell was actually working against them instead of with them. So that was one of the things we were challenged with, was kind of turning that perspective around. We also had a lot of gaps in the education. You know, I'm one person and we had 12 facilities, so I can't be everywhere at once. So we had some gaps with the standardized education at that enterprise level. The data we were capturing was also not really capturing the consistency in practice. We were focusing on quantity. How many total medicine views are we having, as opposed to how many of our patients are actually using this tool. So we were not capturing consistency in practice. We also had goals around GetWell, but they were really soft. There wasn't nurse leadership kind of teeth behind them and accountability. So if it's not important to your chief nurses, it's not going to be on the radar of your nurse managers, which means your staff, they're not going to concentrate on it either. And then lastly, we did get requests for more medicine-related health videos. So as we know, the health videos are really good complementary education. They shouldn't be the sole source of medicine teaching, but we definitely could have had a more robust library. So now that we've identified some of the cracks in that foundation, we were really challenged with finding the interventions. How are we going to fix this and turn it around? So for one, our chief nursing officer, Maureen Swick, in December of 2018, finally gave us permission to remove that PIN code page, which was such a big barrier. So that was a win for our system. I also kind of did a tour of the facilities to do some level set education with our patient experience coordinators, our nurse leaders, our clinical informatics coordinators, kind of to get everybody back on board and give them a refresher of what all this tool really had to offer them. We also filled in the education gaps with some LMS on-demand modules. So whereas I couldn't be in 12 places at once, now I could be through these LMS modules. So we just kind of recorded some of those PowerPoints and live demonstrations. And with that, I was able to reach 4,500 teammates as opposed to 5 and 10 here and there. So that was very helpful. We also changed the way we ran our data. So instead of focusing on volume, we started focusing more on consistency. So we were really drilling down to the percentage of patients that had medicine views. And we integrated with Cerner Multum. So we wanted to make sure that our medicine teaching information mirrored what we were sending patients with home with in their depart summary. We also had nurse leader accountability for the first time. So our chief nurses actually bought into it. And once it became a priority for them, it became a priority for everybody. And then lastly, we did kind of beef up that medicine video library. So we went ahead and just added all of the Milner-Fenwick medicine-related videos. So a lot of our teammates felt a lot better about that. So this next slide, it's a little busy, but I just kind of wanted to show you how we're focusing in on your percent of patients that are having a medicine view. So we pull our visit number from the executive dashboard of Management Console, And then we go into reporting and then custom to the utilization medicine database. And that's where we start pulling our individual account ID numbers. So we take that, divide it by the census, and that's how we're coming up with that percentage of patients with medicine views. This is just shows our LMS library. So you can see those 3 middle ones. Those are the ones that we started about February of last year. And as you can see, I was able to reach a lot more teammates through that method of education. I have some that are general to where everybody can watch them, and then I have some that are more clinical oriented. So those are the ones that go through your Cerner tasks, how it documents back, that sort of thing, because you know, your non-clinical teammates, they're gonna zone out when you start talking to them about clinical stuff. So I think it's important to tailor that education to your audience. So now that we've kind of filled in some of those cracks in the foundation, we really need to start garnering buy-in. So our first step, one of our facilities, Kings Mountain, they had started hardwiring medicine teaching back in 2017. So I was able to show this slide to the chief nurses, and the red line is their increased use of GetWell. And if you notice, all of their other HCAHPS related, medicine related metrics started increasing once their GetWell utilization started increasing. So that was kind of the first step that got them interested. From there, as people started using it more, we started having some non-HCAHPS wins. So at our Atrium Health Lincoln location, one of the nurses was showing a patient their medicine list because she inquired about some eye drops, and the patient realized she was allergic to one of her medicines on that list. So then they saw the value from kind of a different lens because this prevented a medication error. So then we started getting more buy-in from that point of view. As the year progressed at our Atrium Health Union location, we started being able to see clear the correlation between the GetWell medicine teaching and the HCAHPS scores. So that yellow line shows their GetWell utilization. And if you can see the other HCAHPS related domains and scores around medicine teaching, they all mirror that exact same trend line and pattern. So as GetWell got better, their HCAHPS got better. As GetWell dipped, their HCAHPS scores dipped. It's a little more pronounced in some of the areas than others, but they all follow that same pattern. So now we've kind of established it improves, there's medicine safety related to it, and there's a clear trend. So next is the outcomes. Were we able to kind of turn all of that around? So the graph on the left is an 18-month trend showing where we started in July of 2018 compared to where we ended in December of 2019. So in July of 2018, we were at about 8.4% of our patients viewed at least one of their medicines that month. And as you can see, we increased, and by the end of 2019, we were at 23.3% of our patients. So we just made a huge increase in how our staff was leveraging this tool. The red line shows how we set our goal. So our goal last year was 30% of total patients. We never reached that goal, but I mean, we made huge strides in our utilization. The one on the right shows as a year in 2018, we went up from 10.5% of patients to the end of 2019 when we averaged over 18% of patients. And then that just shows you as of January 2020, we were already at over 25% of our patients. So we're also in that really good trend upwards. But so we don't get paid on GetWell utilization. So did it matter in the end? Did it affect our HCAHPS scores? So this graph shows our difference between 2018 and 2019. 2018 is in the red, 2019 is in the green. So we actually made improvements and gained back the ground we lost in 2018 in both the domain and all of the individual questions related to medicine teaching. And we gained ground in both top box and percentile rank. So we did see, you know, some real impact there. And that's at an enterprise level, so that's a big ship to turn around. So we're really excited about that type of improvement. But you can really see it more at a granular level. So this is just one unit from Atrium Health Lincoln. The graph on the left shows their GetWell utilization and the increase they experienced. The graph on the right shows their HCAHPS scores for the communication about medicine's domain. So again, you can see that they mirror each other. As GetWell got used more, their HCAHPS scores reflected that. So some of the best practices that we have found around the system, I think just finding the best place in the workflow to do the medicine teaching was huge for the units. It's not a one-size-fits-all. So your telemetry unit's going to be different than maternity, that's going to be different than critical care. So Is it best to do that during rounding, new medicine administration? Do you sit with the patient and do like take 5, that sort of thing? So finding what works best for your unit. I think also engaging support staff to help out with that is huge. We don't want our non-clinical teammates doing medicine teaching per se, but we do want them orienting the patient to where they can find their medicine so that they can teach themselves. We even have some respiratory therapists that are doing medicine teaching during breathing treatments because the patient's already there. They're not really doing anything else, so they're just kind of taking advantage of that opportunity. And the last is using Get Well medicine teaching as an MDI huddle metric. So many of our units have adopted this in their daily huddles. One of the reports that one of our clinical informatics teammates invented was a business objects report that's actually pulling Get Well results from Cerner. And that's how a lot of our facilities are now keeping up. And I'll show you an example of that report in a second. So moving forward, we're looking to update our LMS on-demand education for teammates. We're also looking to continue embedding Get Well and kind of casting a bigger net by embedding it in existing nurse education. So we're really excited. We finally have this as part of new nurse orientation that's going to catch all nurses coming into our system, both student nurses and faculty nurses. We're also thinking about embedding Get Well educational videos into some of our medicine orders. That way they're automatically getting that video when that medicine is ordered, and we're not relying on our nurses to have to remember to order that. And then lastly, our business objects report. It started at Lincoln. They kind of invented that, and then we're now spreading it to our other facilities. What's great about this report is it is automated. So whereas with Management Console, you can't set up automatic reports right now, this allows our nurses to receive a daily email to their inbox that shows their patient list, and you can see up there, it clearly shows the gaps of which patients have not had medicine teaching yet. So they can use that in their huddles, they can use that as their nurse leader rounding, and they can really pinpoint those gaps in the patient education. So this slide is going to show the impact of that business objects report. So on the left, again, that's Lincoln who created this report. And you can see they started about late August, and you can see how they trended upwards from there. As soon as they started that report, they were already above goal. Our Atrium Health Cleveland facility adopted this report mid-January, and you can see on the right, they went from 14.9% of their patients in December to already at 39.5 just in a half a month of January. So this report is incredibly impactful. And to kind of show you the fruits of that labor, so again, on the left, that's Lincoln, and as soon as they started using it, their HCAHPS mirrored and followed and increased. Same thing, this is still Lincoln. Once again, they started using that report. Once they did that, their HCAHPS scores followed suit and also increased. So really, really impactful report. And that's all I have for y'all today. I will turn it over to Kaiser.
Good morning. Good morning, Washington. Well, let me track back. That's a national conference. Good morning, United States. All right, my name is Wendy Nohor-Jose. I'm from Kaiser Panorama City. Today, I and my team will be talking about how medication teaching improves HCAHPS scores, our initiatives in our particular unit in Kaiser Panorama City. It is with great pride that I introduce to your organization. I work for Kaiser Permanente, the #1 HMO in the entire United States. We have 39 hospitals in the entire United States. We are an integrated healthcare delivery system, an HMO, and Panorama City is located in the northern part of Los Angeles. For those of you sports fanatics, we are in the northern part of Dodgers and Staples. For those of you who are in the show business side, we are on the northern side of the Tinseltown in Hollywood. We have 267,684 members, 218 licensed hospital beds, 74,671 inpatient days. We are voted by Leapfrog in the US as grade A for safety, and we are voted as one of the best places to work for diversity. With that said, we are also being ranked by HCAHPS. we are confronted with a concern. Our scores were below regional target. You will see we actually took 2 buckets out of HCAHPS. The first bucket is nurse communication, the second bucket being medication teaching. Out of the nurse communication bucket, we have the composite of nurses explaining things in a manner that patient can understand. And we took the 2 buckets out of that, 2 composites out of the medication teaching bucket that says, are we explaining what is the purpose of the medication, and are we explaining the side effects? You see, in January, we fell to a low ebb. Look at the 10 portion of that. We are at 47.5% in terms of medication side effects. Truly, if you are a nurse, teaching is one of the many hats that you wear. And if you are explaining things in a manner that patient can understand, you will explain what the medication is for and what are the possible side effects of the medication. But why are scores not reflecting that? We were stumped. Our leadership would often say, telemetry, let's all lean in towards telemetry and wrap around them. How can we help you? We were stumped because the efforts were there. We were stumped because we have great nurses. And then we have amazing doctors, and we have the technology. Yet the efforts are not translated into numbers. It's not being translated into HCAHPS. We wanted to do a deep dive. We wanted to do a root cause analysis. What's happening? So we turned back to our patients. On June 12 of 2019, the leadership, the Magnet Council members of nursing, invited some of our patients and their families to sit down with us. Who can we better gauge our understanding from than the receivers of our care? We wanted to gauge their needs, their wants. And we wanted to provide what we aim for, to have a patient and family-centric kind of care. We wanted to hear it from them, and boy, did we hear it. So we wanted to know, we were not listening carefully. We were not being courteous. We're not, apparently, they're saying that we're not treating them with courtesy and respect. And then, are we explaining things in a manner that they can understand? On the other side, in terms of medication teaching, are we explaining things? Are we explaining the purpose and the side effects of the medication? So we strategized. And the best way to strategize is to sit down with the patients. We co-designed a solution with patients and families to improve their care experience. And this is aligning with our pillars of the nursing practice, which is patient and family-centered kind of care. So our project in telemetry was born, the human-centered design, the golden hour. One of the components of that, if you look at the third box, is to have a dedicated time to sit down with patient and do medication teaching. We call it Ask 3, Teach 3. The nurse would teach you 3 things. What is the name of the medication? What is the purpose? And what are the side effects? And then in return, patients would teach us back. And again, this is an evidence-based practice. Teach back is a methodology that is evidence-based. More retention on the part of the patients. So you tell us, patients would tell us, what is the name of the medication that we taught you? What are the indications for the medication? And name just 2 side effects. And the get well component is there. Ask 3 and teach 3. So with this kind of methodology of project, we are doing high tech and high touch. Nursing will not be nursing if not for the human side. And then we're also using the technology to have the high-tech portion of it. We're using multimodal approach in terms of medication teaching. And on that note, I turn you over to Roque Garvida.
Thank you, Wendy. My name is Roque Garvida, and I'm the Informatics Practice Specialist and Clinical Lead for GetWell. So this slide shows you our GetConnected Journey with GetWell. In November of 2016, we implemented GetWell Network inpatient using our smart TV, the first in GetWell Network history. We're so fortunate to have innovative Senior Vice President Payman Roshan, who is our champion for patient engagement. Part of the original design is the medication education pathway. We also incorporated a pop-up question for patients if they understand their medications and their side effects. That fires every 1 p.m. In August of 2018, we added a new feature for medication teaching. When there's a new medication order, it creates a pop-up at the bottom of the TV asking the patient if they want to learn about their new medication or later. In August of 2019, nurses have been asking this feature wherein the medication teaching understanding is documented in our EMR, which is our KP Health Connect and Epic platform. This slide is a snapshot of our original medication teaching workflow that was originally designed and developed by the clinical design team in collaboration with GetWell Network. From the patient's medications list in Pyxis, it's integrated into GetWell Network, and then the only problem with this workflow at the beginning is that after the medication has been taught to the patient or the patient learned about the medication, the nurse has to manually document in our EMR. So the nurses were not happy about that. The first picture on the left represents our current build for our medication teaching tile. Learning about my medicines tile sits on the top of the priority, as part of our priority tiles. Once the patient clicks the tile, it shows a screen like the picture on the right, and we incorporated the Ask 3 Teach 3 initiative that Wendy mentioned earlier, wherein we encourage the patients to ask the nurse if they give their medications these 3 questions. What is the name of the medication? Why do I need to take it? And what are the 2 possible side effects? And on the left, you can see the pop-up question when there's a new medication order. This is a snapshot of the different features when a patient or a nurse open the medication. And in this example, we have Zofran. So on the left is the name of the medication, and then you click further, and you could look at the purpose of the medication, and then you click further below, and you could see the medication side effects. So the patient or the nurse can utilize this functionality. Also, they could learn any medication that they want that is not part of their medication list, which is integrated into Pyxis. This screenshots shows you the patient's response after viewing the medication. On the left, if they select the check mark, it indicates the patient understanding of the medication. The middle, if they select the mail icon, it allows the patient to send the medication information to their email address. And on the right, if they click the question mark icon, it's basically indicating that the patient needs more reinforcement, and the patient can see that in their email or in the GetWell Network console. So basically, this slide is the bidirectional documentation in our EMR. So once the patient selects that check mark or thumb mark, it automatically documents in our EMR, which is a win-win for our nurses. They love this feature, and they were happy that their request has been heard and came into fruition. So Dennis is going to discuss the strategies, additional strategies that we have for this initiative.
Good morning, everyone. My name is Dennis Ramirez. I'm the Department Administrator for the Telemetry Unit of Kaiser Panorama City. I'm here to discuss to you about additional strategies that we incorporated on our project. So on the nursing part, we are providing written literature about the new medication. On admission, a nurse is expected to hand out a green folder. This green folder is the medication education folder, and we have 2 tools that we incorporate on that green folder. We have a single medication education sheet, which also is colorful so that the patient can remember the medication. And we also have a multi-medication sheet arranged according to alphabetical order, according to the commonly used medications at telemetry unit. And then also, we are reviewing the medication every patient encounter, especially when we are passing medications. We have to review again the action and the side effects using the GetWell network functionality. And then on the physician side, also the physicians are reinforcing the education for medication. And also, they discuss new medication at the bedside, and they also invite the nurses with them at the bedside. And also, they support as a champion for nurses. And the results of the medication education initiatives, we compared the volume of patients in telemetry unit, which is represented by the green bar, and then the blue bar is also represented by patients viewing their medication education on the GetWell network. We launched our project, the Human Centered Design, the Golden Hour, on July 2019. And past that, as you can see, the utilization of the GetWell network for education also has increased. And then we relate that on our HCAHPS scores. So as Wendy has mentioned, we picked nurses explaining things understandably, and also for the medication, we use the action and the side effects to measure. So the first line graph there, to tell the story, we use the line graph. The blue bar represents our explaining things understandably, and then the green line represents our purpose of the medication, and the orange line represents the side effects. So on July 19, we launched a project. There was an uptick on the scores between August to September, because during that time, everything is hot, all the project is fresh, and we take accountability for this. We had a drift, and from that drift, we learned, that there's factors that we need to solve to sustain the improvement. And also, there was a positive thing also that happened during this time. Number of the on-the-spot recognitions increased. About 5 to 10 on-the-spot recognitions was given to me as manager daily. Imagine that. And then also, the report from Press Gainey also, with regards to negative comments, decreased. And actually, last month, we have 0 negative comments also from patients. So these are the barriers that we encountered to sustain the momentum. The first one is the staff, the accountability of the staff, and also consistency of teaching the patients about their medications. And also the patients. Some patients are technologically challenged, according to educational background, and also elderly people doesn't want, to use the GetWell network, so that's why we had the green folder to back that one up. And also the acuity of the patients. Sometimes they cannot be taught because, they're obtunded. And also motivation to learn of the patients. And the last one is the leadership. The consistency of rounding and audits are lacking also. And the timeliness of escalation process from the GetWell networks. Every time we have patients saying no, let's say, are the nurses teaching you the side effects of the medication, and they would say no, sometimes the follow-up is not there. And then also the reports, the daily and the monthly reports are sometimes also not consistent. So for sustainability steps, we devised 4 ways. The 4 ways that we could sustain it is through leadership engagement. So as I gathered all my leaders in telemetry, and we regrouped. We set a goal to round on our patients 100% of the time, and if we are really pressed for time, we strategize. We told them we have to pick 1 patient of a nurse and interview them and check for completeness of their education. If a nurse, let's say, fails to educate the patient on the side effects, we will send back that nurse to the patient room and teach the patient again, and this nurse will get a peer-to-peer feedback. And then if this nurse consistently not do his work, then this nurse will be referred to me as the manager, and we will do corrective action if needed. And then for staff engagement, we also make sure that we explain what's in it for them and also for our patients. And then also we celebrate successes. And we did some pizza parties every time we meet our goals. And also during huddles, we share the positive and negative comments of our patients so that the staff, if ever they are caring for their patients, they can adjust their care accordingly. And for clinical adoption, all the staff were trained with the golden hour. And the next step, actually, according to our chief nurse executive, is to spread this best practice to the other units. And then for the system utilization, we have a dedicated project manager who furnishes us daily reports of the GetWell network utilization about medication teaching, and also a monthly report which reflects each unit's usage of the GetWell network utilization for medication teaching. And we give awards to the top 5 nurses who assigns education and the completeness also of their assigned education. And I would just like to acknowledge also the following individuals on the slide for helping us reach our goals and also making into fruition for us to present here in the GetWell Network Conference. And as you can see, our SVP is there, our Chief Nurse Executive, and so on. I don't want to mention all the names. It will take time. And now I'm going to pass the microphone to Wendy Nahor to close the presentation.
I want you all to think about an inverted triangle. Are we thinking about it? Inverted triangle? All right, how many in the audience are physicians, leaders, management, IT? Thank you for supporting us. That inverted triangle, information trickles from the top down. Now, I'm a clinical nurse, and I'll be partial to this. How many in the audience are nurses? With a raise of hands? Thank you. We honor you. We support you. This year 2020 is the year of the nurse. This marks the 200th birthday of the mother of nursing, Florence Nightingale. And think about the triangle. We are the frontliners of care, of healthcare. We are on the bottom, we are the frontliners, yet we are providing the base and the foundation of healthcare. Think about that. And as Florence Nightingale says, nursing is a progressive art such that to stand still is to go backwards. On that note, we are Kaiser Permanente, and we are connected.
Yeah. All right. We're going to open it up for questions.
Hi, this question is from Misty, I think. How did you maintain and manage a patient's privacy when you removed the PIN code from the medication screen?
So, can y'all hear me through this mic? Okay. So even though we took down the PIN code, what we were kind of discussing and making that decision was that a lot of times our nurses were passing out handouts about the medicines. So there was just as much likelihood of the family finding that piece of paper that related to the patient's medicine as, if not more likely, than actually getting on the TV and clicking "See My Medicines." So we did lose that little piece of privacy, but when we asked GetWell how many of their clients actually used that PIN code, I think it was like 6% or something like that. So we realized that we were kind of going against the grain. So I don't think there's anything wrong with having that PIN code. It was just such a big barrier from us, from a nurse remembering to educate the patient about it perspective to the patients just couldn't remember. It was their birth year, but I mean, when you take into account the influx of information a patient's getting when they get admitted, they don't feel well, they're getting all this new information thrown at them, they're not gonna remember it. So we just really felt like it outweighed the cost of it by getting rid of that PIN code.
You got me on this time? We're on. Any other questions?
Yeah. Hello. Hey there, I'm Brent Brewer from Carillion Clinic in Roanoke, Virginia. I'm just wondering from both of you all how you have addressed nurses' kind of physical position in teaching, using the medication teaching pathway. So where your TV is located, where the nurses are located, and whether they're using the pillow speaker or the keyboard to use that.
So we actually had training for each of the nurses. We have a sim lab, and we have dedicated also places for where to place the keyboard, and also we only use keyboard and also the remote for our GetWell network. So most of the time, we have our when we do our golden hour, we make sure that we orient the patient, using the call light of the patient, where you can control the GetWell network. And then also the keyboard is also placed at the bedside of the patient. So we always do the rounds and we check it for this for the placement.
So we didn't do anything specific around that, but in my LMS education, I do go over the equipment. So it's really up to the nurse as far as if they're more comfortable with the keyboard versus the pillow speaker. I will say one thing that we try to do with our nurses is let them choose the best position in the room, the best time to do it. So a lot of times they do that during new medicine administration at the bedside. Some of our facilities do what's called commit to sit or take 5, where they actually make an effort to sit on the patient's bed with them and have that conversation. So it's really up to the nurse, what they're comfortable with, what the situation in the room is. They just really have to fill that out for themselves, I think.
Misty, it looks like you guys had some really great results when you implemented the business objects report. Can you speak a little bit to that? Is that a Cerner report, and how did you guys develop that?
So the teammate that actually invented that was not able to come. She's one of our clinical informatics coordinators. It is not a Cerner report, though. I think the platform itself is called Business Objects. And what she does is she sets up queries that actually pull from the EMR when it says our Get Well Medicine teaching results as a data sheet. So it pulls the last time that patient had a result for Get Well data sheet. Same thing with health videos. It pulls the last time from Cerner that patient had a Get Well video result. So if you've got a informatics team at your facility, which I'm sure everybody does, they may be more familiar with business objects than I am and can probably speak to that more. But I do know that they set it up through the queries, and they can actually set up a distribution list. So a lot of places are setting it up to where their nurse leaders, their clinical supervisors, they receive that report at about 6 a.m. every morning directly to their email. So what that does is help them not have to go into Get Well Management Console and kind of sort through patients. It's just a much more efficient process.
Hi, I'm Christy Grau from Get Well Network, and I have a question about the medication content that you're using. Is it the Lexicomp database, or like the Teach3, is that something that your pharmacist came up with for the content piece?
For Kaiser Permanente, we use the Lexicomp.
Integrated with Cerner Multum at Atrium, so that our content on Get Well Network matches what the patient gets in their D-part summary of their discharge instructions, since we're integrated with the Cerner EMR.
Okay, and then a little further question. From that Lexicomp database, do you just pull out those 3 points that you want just to simplify it for the patient?
Correct.
Okay, and who does that work? Is that pharmacy?
Yes, we work with the pharmacy in collaboration with nursing. And it's a regional template. So all the Kaiser in Southern California has the same medication education templates.
He likes to turn my mic off. Anyone else have a question? All right. Great job. Excellent.